Today, we're going to discuss anesthesia procedures, methods, and techniques, a potpourri of anesthetic issues that you may face when undertaking the ABA examinations. Now let's turn our attention to the practical aspects of management of the airway in the adult. A question for you to consider next. Which of the following characteristics carries the highest odds ratio for predicting a difficult mask ventilation? A, the presence of a beard. B, the lack of teeth. C, age greater than 55 years. And D, a history of snoring. And the answer, the presence of a beard. Recently, there's been a great deal of interest in identifying those characteristics associated with difficult mask ventilation, something that really wasn't the focus of interest. We spent a lot of time trying to identify the factors responsible for difficult tracheal intubation, but not mask ventilation, at least until recently. And so in a number of studies, the results have been coming clearer and clearer that there are some significant factors that are associated with difficult mask ventilation. In one study, the criteria for difficult mask ventilation, which of course is open to question, is the inability of one anesthesiologist to maintain a saturation more than 92%, significant leak around the gas mask, the need for more than 4 liters of oxygen, fresh gas flow, no chest movement, 2 per-handed mask ventilation needed, and a change of operator required. And in the end, the independent factors associated with difficult mask ventilation by far and away were shown here on the slide, 5 of them, and number 1 was the presence of a beard. But as well, large body mass index, lack of teeth, age, and snoring, as we heard a few minutes ago. So Langeron has evaluated over 1,000 patients. 5% were described or characterized as difficult mask ventilations, and they discovered or identified 2 predictors, as we saw earlier, that indicated a high likelihood of mask ventilation. Ketterpaul looked at 22,000 patients with different criteria and found difficult mask ventilation in 1.5%. They added Mallampati scale and poor mandibular protrusion in their description of a difficult mask ventilation. In a meta-analysis, Shiga concluded physical predictors of difficult laryngoscopy now and concluded that the failure of individual indices to predict difficult laryngoscopy suggests a combination of tests may be useful. So, in order to get to that, let's ask the next question. In assessing the risk of difficult intubation, which of the following metrics carries the highest value? A, the specificity of the thyromental distance. B, sensitivity of mouth opening. C, sensitivity of Mallampati scale. And D, specificity of Mallampati scale. The answer is the specificity of the thyromental distance. Well, difficult intubation shown here in the results of, and summarized in Barish's textbook and published by Shiga. You can see that the Mallampati classification had a sensitivity and a high specificity, but the thyromental distance had the highest specificity. And so what we see now in summarizing our airway management is, number 1, the tolerance of apnea is the imbalance of oxygen relative to the acquisition. And so we'll talk a bit about how to prepare the patient in a moment. But in terms of ventilation on the far right, we can see that facial hair and a beard is a very important factor. Obesity, neck thickness, and edentulous are characteristics of difficult face mask ventilation. In terms of intubation in the middle, the factors are the interincisor distance, temporomandibular distance, thyromental distance, Mallampati scale, mandibular protrusion, neck thickness, and range of motion. So we have fairly well-established criteria now for all of these factors. Now, when it comes to obesity, these patients were initially, at the beginning of bariatric surgery, identified as huge problems for intubation. But in fact, it became exercise in recognizing that preparation of the patient for laryngoscopy needs more considerations than we had given it to in the obese patient. You can see here on this slide where A is the tragus of the mandible, of the ear on the left side, and that arrow points to the clivus, which is at the base of the skull. That corresponds to C, which is the back of the nasopharynx. And when we track a line from the clivus or nasopharynx to the vocal cords, base of the tongue and through the vocal cords, we can see that if we looked in the mouth, we'd be having to look uphill to go from C to D. Our eyes could not follow that line from C to D because it's uphill. And that's because the patient's lying in an unfavorable position, the neutral position. If, on the other hand, we raise the head so that once again, the tragus and the clivus are aligned, but the head is in the sniffing position, you can see that if you looked in the mouth at the nasopharynx, you'd be looking down into the vocal cords at D, which raises the question, why or how you must align the neck in order to see the larynx. And that is, the tragus must be higher than the sternal notch in order for you to be able to view into the mouth and see the tragus, see the vocal cords. How to do that? We have to ramp the back up to the 25 degrees that we are prepared to do, for example, in obese patients, to preoxygenate them, and then almost double the size of the head lift. And we can see that. I think we have a slide coming up. So to optimize the airway, we normally have the occiput raised about 7 centimeters, but in the obese patient, we need a much greater elevation of the occiput. It doesn't give us enough extension. And here you can see on the left-hand side what looks like a patient in perhaps Trendelenburg, but actually this patient is just neutral, lying flat. And they are not in the sniffing position, or they're in the classic sniffing position, which is the head is elevated, but the tragus is well below the angle of Louis in the sternal notch, or the sternal notch. On the right-hand side, we see the head is raised up twice as much as in the preceding picture, and the bed is actually tilted in a little 25-degree head-up position. And this, you can see, raises the tragus, and if you were to imagine where the sternal notch is, or the angle of Louis, the tragus is above the sternal notch. And that way, when you look in the mouth, you'll be looking down to the larynx. Now, the next slide just briefly tells you about the paraglossal or molar approach to laryngoscopy. And when Miller first described the Miller blade, I think he was in El Paso, Texas, in the 40s, he applied a lead tooth guard to the maxilla of all the teeth. And that could only mean one thing, that he knew that he would be popping out teeth, the central incisors, when he applied the blade in the midline. And so the pediatric approach, or the approach you should use today for the Miller blade, is to apply it over the lateral incisors or bicuspids, as you can see on the right-hand side, because as the left side shows you, for a child with dental x-rays, the central incisor, the yellow arrow to the far left, the root of that central incisor is very short, whereas the bicuspid, the arrow second to the left, and the lateral incisor and bicuspid, these other two arrows, have much deeper roots, or two roots, that secure the tooth in the alveolar ridge. When a dentist wants to remove a central incisor, he simply pushes it into the alveolar ridge. And that's what you'll do with a Miller blade if you apply it in the midline without a tooth guard. So you don't apply the Miller blade in the midline or over that central incisor, the one with the yellow left arrow. You apply it over the lateral incisors or bicuspids, and you can't knock those teeth out by leaning on them. Our next question. A healthy patient undergoes a mild to moderate degree of sedation using propofol. Moderate airway obstruction is noted by diminished but not completely absent end-tidal CO2 trace. Relaxation of which of the following structures most likely accounts for this? A, the hard palate, B, the soft palate, B, the soft palate, C, the epiglottis, and D, the tongue. The answer is the soft palate. Airway obstruction is, while awake, airway patency rather, is maintained by muscle tone. When consciousness is lost, muscle tone fails, and collapse of the airway occurs under gravity. The order of importance of obstructing tissues is soft palate, or the velopharynx, greater than epiglottis, greater than the tongue. Head extension, which is tension on the strap muscles of the neck, and jaw thrust move the hyoid-bone and attached structures anteriorly, relieving airway obstruction to a variable extent. Jaw thrust also decreases obstruction of the velopharynx, and as I mentioned, you need to apply it at the ascending ramus of the at the coronoid processes, not at the angle. The lateral position, I should also point out, increases the volume in the airway about 30%. So that is a maneuver, although it is more difficult to maintain by the face mask when the child's or patient's lying in the left decubitus. And as we mentioned in the pediatric lecture, here once again is optimizing the jaw thrust by the way that it is traditionally taught, of applying jaw thrust at the angle of the mandible, which does anteriorly translocate the jaw, but doesn't give you any benefit of the rotational effects, which need your fingers to be applied at the top of the ascending ramus of the mandible, pulled towards the hairline, and you'll see rotational movement of the jaw. Preoxygenation is crucial, particularly in the obese patient undergoing anesthesia, because it replaces the nitrogen in the lung volume with oxygen and provides a larger reservoir if periods of apnea occur. Preoxygenation with 100% oxygen can be achieved by a tight-fitting face mask for 5 minutes of spontaneously breathing a patient, and it gives up to 10 minutes of oxygen reserve if apnea were to occur. In non-obese adults who breathe 100% oxygen, saturation was maintained for more than 90% for 6 minutes. But in the obese patient, they experienced desaturation in as quick as 2.7 minutes, less than 50%. And that basically speaks to the fact that supine, the obese patients have more atelectasis and they're unable to achieve as large a reservoir as if they were either slender or 25-30 degrees head up. So under ideal conditions, breathing 21% oxygen, the average patient will experience desaturation to less than 90% after 2 minutes. So the most common reason for not achieving maximum alveolar oxygen stores is a loose-fitting mask, allowing entrainment of room air. So four vital capacity breaths of 100% oxygen over 30 seconds gives you a pretty high PO2, but the time to desaturation is consistently shorter compared to traditional techniques, so it's not an ideal approach. A modified vital capacity breath takes 8 deep breaths in a 60-second period, and that may prolong the time to desaturation. Pharyngeal insufflation, while doing whatever airway maneuver, can maintain the duration of a normal or acceptable saturation. For example, giving 3 liters per minute via catheter in the mouth. In the obese patient, 25 degrees head up does provide you with an additional benefit of oxygen reserve and delayed desaturation. When insufflating the pilot balloon of a laryngeal mask airway after it's inserted, the intracuff pressure should never exceed which of the following values? A, 20 centimeters of water, B, 40 centimeters of water, C, 60 centimeters of water, and D, 80 centimeters of water. And the correct answer is C, 60 centimeters of water. Laryngeal mask airway has been revolutionary in managing the adult airway. It's critical to the difficult airway situation and a bailout if a failure to intubate occurs. But its success is due to ability to reliably insert it and the avoidance of any complications, which have occurred quite infrequently. Choose the largest airway that comfortably fits in the oral cavity to get the best results, and inflate to the minimum pressure. So that's why a cuff that is too small may require pressures in excess of 60 centimeters of water, and we should avoid that as ever possible. And don't forget that these cuffs may expand in the presence of nitrous oxide to values in excess of 60, even if you measured the intracuff pressure at the beginning. There is no difference in gastric inflation with positive pressure ventilation, provided the pressure is less than 17 centimeters of water when comparing an LMA with an endotracheal tube. And when using an LMA, one should limit the tidal volume to 8 cc's per kilo and airway pressures less than 20. And that's, again, to avoid gastric inflation. People have used the laryngeal mask airway in any position you can possibly imagine. That doesn't necessarily mean that it's the wisest thing to do. And I would be very careful. Remember that the laryngeal mask airway was invented not to replace the endotracheal tube, but to replace a face mask. Although the manufacturer recommends using a laryngeal mask airway for a maximum of 2 to 3 hours, some have used it for more than 24 hours. Traumatic pharyngeal mucosa changes from a supraglottic airway have been reported with delayed onset when compared with the effects of endotracheal tube. So we do have to be a little careful. Now, it's important to be sure that we're thoroughly familiar with the difficult airway algorithm when facing a clinical scenario. Awake intubation is an alternative that may be used with sedation or topical anesthesia, and certainly in the patient who's a completely unmanageable airway and has contraindications to any form of anesthesia, this is an alternative. But there are those situations when we run into a difficult airway after anesthesia is induced, whether we have an initial intubation attempt that's unsuccessful. From that point onwards, you begin to follow the scenario of calling for help, get spontaneous ventilation resumed, or managing the ventilation manually, or awakening the patient. And that breaks us down into two choices: either face mask ventilation is adequate or it's inadequate. And if it's adequate, then we can go to a non-emergency pathway and look for alternate ways to secure the airway. But if ventilation is not adequate, then we have to intervene. We can attempt an LMA, and if an LMA is adequate, again, we buy the time to look at another airway. If it's not adequate, now we have to look at an emergency airway and look at means of maintaining oxygenation and ventilation, and that can lead to catastrophic airway, where that may involve tracheotomy or a cricoid or tracheal puncture in order to ensure oxygenation and ventilation. So the decision-making pathway has to do with face mask ventilation is adequate, and we talked how to look for a difficult face mask ventilation earlier, whether laryngeal mask airway is adequate, and we talked a bit about that, and then what to do with the non-emergency pathway and consider the alternate choices for difficult intubation. And these are shown at the bottom of the slide: different laryngoscope blade, another user, reposition the head, fiber optic intubation, glide scope, or whatever other technique you want to use. There's really no proof one technique is superior to the other. In your hands, you pick the best technique. If face mask ventilation is not adequate and the LMA is not adequate, that's when we get into real trouble, and that's what, as I said, we move to the emergency airway situations, which may be transtracheal ventilation, rigid bronchoscopy, and so forth. Our next question is regarding topical anesthesia. 400 milligrams of lidocaine is applied topically to the upper airway in preparation for an awake intubation. When will the patient experience peak blood levels of local anesthesia? A, 15 minutes, B, 30 minutes, C, 60 minutes, and D, 120 minutes. The answer is 60 minutes. With transtracheal jet ventilation, if a cricoid catheter has been placed, or cricothyroid catheter rather, has been placed in the airway, an oxygen source is attached, and a high pressure system can be used to ventilate the lungs. It's critical to have a pressure limited peak inspiratory pressure of oxygen of less than 30 centimeters of psi. This was not the case in the past. In the past, they had unregulated pressure jet ventilation, and that led to serious complications, which is why this is not used anymore in children. But now that we have complete control over the peak inspiratory pressure, it's certainly a possibility if a catheter is situated in even a child. If a 16-gauge catheter has been placed in the system, you'll be able to deliver a tidal volume of 400 to 700 cc's. Low-pressure systems cannot provide enough flow to expand the chest for oxygenation, a common gas outlet of 20 psi, for example. But you probably would work in a child because those low pressures are needed. An unregulated oxygen source is generally 50 psi, and that may be a fine source, but that should never be connected directly to the airway unless it's somehow controllable. For transtracheal jet ventilation, complications are related to barotrauma, as I mentioned, with cervical mediastinal emphysema, which could be disastrous, pneumothorax, and tension pneumothorax leading to cardiac arrest. The causes of penetration of airway into the paratracheal space include all of the following: insufflation of gas through a misplaced catheter, multiple tracheal punctures, or migration due to coughing. Bilateral tension pneumothorax, as I mentioned, has been reported and is catastrophic, leading to cardiac arrest. Well, that completes our airway discussion, a quick romp through a number of subjects that identify the difficult airway, lead us to difficult mass ventilations, the factors associated with laryngoscopy, and then